Thank you, Dr. Panda, for the kind words. And if you have been in as long as I have been in practice, you'll have all kind of complications. And obviously, if you are not lucky enough to have the excellent hand that Dr. Pandav has, then the chances are likely to increase. So anyway, we'll just go over them and then I'll just show you some slides. Obviously, one of the problems that can occur very nicely, everybody has covered the basics. So we can have a flat anterior chamber, tube migration, exposure, tube retraction, tube obstruction. So here the chamber is gone completely shallow, you can see, and it's actually a nightmare so many times. So it may be easy to do a valve as Dr. Pandav has so nicely shown, but sometimes the complications are a nightmare indeed. And most of these cases are anyway very difficult primarily. So it is a tough job anyway. And you can have an exposed tube. And the biggest problem with the exposed tube is that the people in this, a lot of people in the periphery don't have a clue to what a glaucoma valve surgery is. So they'll see in the cornea, they'll see the tube is perfectly placed. They'll just not go out and see that the tube is exposed. And by the time they realize, or by the time they send the patient, it is already infected. So it is so common to find that kind of a problem. And obviously the tube can be blocked, the iris can just cover over it, and or you can have a, again the same thing, shallow chamber causing a completely this thing. There could be a hypotony. Obviously when you have a flat anterior chamber, you have an associated hypotony. You can have a serious hemorrhage as well. And most of these cases we do observe only, and if you give atropine, steroids, and if you give, sometimes we have to give systemic steroids as well, and they do tend to settle down. But obviously, if you have a long-standing flat anterior chamber with kissing choroidals, and the vision is really gone down, then we may have to intervene, and we do have to intervene at times. And you can have massive choroidals which may require intervention. Again, suprachoroidal hemorrhage is a nightmare. You can have encapsulation and corneal graft failure. So you can have big cyst and bleb formations like that. And in the pediatric cases specifically, you can have almost 3 to 5% of the cases getting into squints. There could be corneal decomposition and obviously the dreaded endophthalmitis and scleral perforation. So there can be a tube corneal touch, which is not uncommon at all, as you can see over here. And endoff is something that we never want to see, but you still have to face it. So you wake, you always do your valve nicely, but the next day you wake up and you find that the chamber is completely shallow, and it's extremely shallow. You have, the tube is touching the cornea, so you have to reopen it, and then we have to pass a suture like they were showing in the Adi valve. So you have to basically pass a 6-0 vicryl to close up the tube over here so that there's no drainage through this. And be very careful. The first time I did this, I was so intense on that I cut the tube into two. So be careful, gently close it, and then you use a side port or a MBR blade, whatever you have to get into the anterior chamber. If it is very, very tricky, you can use a 30 gauge needle. Just get into it, pump in some fluid over there to see that to reform the chamber. Once the chamber reforms, you'll get an idea that whether it is there any other leak over there? Have you increased the size of the opening by the 23 gauge? Or was it just the valve which is malplaying? And once we see this and we realize that yes, the chamber is well formed now, you realize that possibly that was the cause which you have taken care of. Again, sometimes what happens is that you find that there's a hemorrhage over there. Somebody sent this case to us. The tube is a little on the longer side. Luckily, it's a fully vitrectomized eye. So you open it up again, and so you open up the valve, you open up the areas, and use a side port, put in a AC maintainer, and go in and clean up the hemorrhage over there. Open up, take out the tube, shorten up the tube, go into the posterior chamber, because already it's a good vitrectomized eye, as the surgeon had informed us. And then instead of the anterior chamber, we go into the posterior chamber and place the tube over there, which is nicely seen. Always place the tube to an extent that it can be easily visualized in the pupillary area. So that is very, very important. And obviously, you have to be sure that the vitrectomy is complete. Again, you have done a good job. Everything is in place. 6 vision pressures are controlled, and then the chap gets injured, the lens gets subluxated, the pressures get elevated, and then you realize that what has happened is that some of the vitreous has come on from the tilted IOL and gone anteriorly and blocked the tube. So you will have to make a 2-port vitrectomy over there, 2 or 3-port, and then what you do is that you know that there's a vitreous in the tube, so you inject tricort, and when you inject tricort, you realize that yes, there the vitreous is filling the tube. So then you go in with your cutter and actually just use the suction over there. You already have done a vitrectomy from the posterior areas so that all this area is clear. And then you just pull out this plug of vitreous which is present over there. So this has to be done. Suppose it is just a little bit of this thing, so sorry. If suppose it's just a little bit of it, then you can do it by just the laser. But if it is a lot of it, then you have to do a vitrectomy, and then we go in from the other side and actually push in a 30 gauge needle and see whether it is open and everything is good. And once you are sure that yes, the fluid is flowing through, then you are happy and you can see that no vitreous in the AC or in the posterior areas, and then you can close it up. Again, we are doing a lot of posterior valves, and in a diabetic, sometimes our retina surgeon said that it's not possible to do a full vitrectomy, but the result was evident. For 1 week, everything was fine, and then suddenly we realized that the entire vitreous, whatever vitreous was left by him, the PVD occurred, and the entire thing came forward and blocked the tube. And again, you can see how a plug has formed of vitreous into the tube, which has again to be sucked out of that area, and the entire vitreous now has to be removed. So we have learnt our lessons. So whatever time it takes, you have to induce a PVD, good a base dissection, as extensive in vitrectomy as you can do. Otherwise, you'll have to go in as we have to do in a few of the times. And we have published our this thing in Pan American Journal of Ophthalmology, where basically the pars plana between tubes we have described in detail. Another interesting thing that happened to us was that while placing a valve in this, we realized that it was too close to the cornea, and then suddenly I realized that I had the cut tube in my hand. So what we did was that we just placed this cut part under the thing to angle it away from the cornea. And then we just sutured this up over here, and that was not described before because, like I said, unless your hand is funny, you cannot get all the complications that sometimes we get. But this really worked wonders for us. And Dr. Vinay Gupta from AIIMS also did with me a couple of these cases, and they did well. We were a little worried whether the flow would be normal, but the flow was normal. And a lot of these cases have been done 5, 7, 8 years back and are doing well for us. And we published this in a new approach as ophthalmology at point of care. Again, many a times, as I think people have shown before also, there could be very well, things could be working well for a long time, and then suddenly there is a huge cyst formation, the pressure starts going up. What do we do? In a child, do we do a repeat AGV or do we do a DLCP? Or what you can do is you can just open up the cyst over there. So obviously you have to have first AC maintainer, you have to apply inferiorly, and then you have a look at the cyst, open up the cyst, and you realize that the huge cyst is formed that I think we have also shown very nicely. So you excise the cyst, and you take out all the fibrous tissue, as extensive excision as you can do. As you can see, the plate is perfectly normal, nothing has happened over there, but it is this thick scar tissue that is formed on top of it. And this fibrous capsule, we try and do as huge a dissection as we can, not trying to damage the plate by any chance, and then putting in the mitomycin C over there in order to prevent any further fibrosis. As you can see, it's a huge cyst over there. And then once that part is done, wash it up and close it up, and the child as well. Sometimes the tube does get exposed, as we said, And then we have to, unfortunately, many of these cases, the conjunctiva is very, very friable. And it is practically impossible to pull the conjunctiva over to try and do this. And if you just try and place a conjunctival flap over there, it will not succeed. So you have to actually cut out a scleral flap of the size, push it underneath. You can either suture it up or you can place a glue over there to really make it stable over there. Once that part is covered, then you can try and use a cut out the conjunctiva from one of the sides. And once you have enough conjunctiva, obviously whenever you are taking out whatever the size, you must have at least 1/3 larger piece over there for allowing it to retract. And once that part is covered, then one can just suture it up over there. But these are messy cases definitely, because initially we obviously try and undermine and get the thing to oppose by itself. It is very, very important in these situations to usually give doxycycline, which I learned from Sirisha's paper, Sirisha and Lakshmi's paper, and really works wonders. That the healing is very, very good by giving doxycycline for some time. And once you suture this up, I think that part is over. However, sometimes the eye is bad. It's only PLPR inaccurate. A lot of hypotony, tube is exposed, and there's a leaking area all around it. All you want to do is to preserve the structure and prevent endophthalmitis. So in these situations, all you want to do is to just take out the tube and close up the area firmly in order to not allow. So whenever we are taking out the tube, we basically have to, we need not take out the plate, because that will be a very messy thing. You just pull it over to allow the other cut end to retract, and then just to maintain the thing, we pushed in some air from anteriorly and posteriorly, and that is how the eye became stable after.
Sir, your video or slides are not moving.
Now is it moving?
No, not yet. It's only on the tube exposure repair slide.
Okay, I think we are pretty much done on that.
Otherwise, you can share it again.
The previous slides were moving?
Yes, sir. It got stuck on the tube exposure slide.
That's all right. That was the last one. So I think thank you very much for your kind attention.